On behalf of Department of Pathology and all the faculty and the residents, we welcome you all on this very auspicious day, having this periodic academic meeting of Lucknow Pathology Group. To start with, we will give our honor and homage to our teacher of teachers, Professor Rajmerotra sir, whom we lost during COVID, which is a very unfortunate event in our life, and the loss is irreparable. He was a very, very nice person, and I am personally obliged for many, many things which he did for me, his father did for me, they did for the department, every one of us. But the thing is that there are certain things which are not in our hand, and the demise is a very sad demise on part of all the department of pathology, every one of us. It is a great and colossal loss. With heavy heart, with all the faculty, all the residents, I pray to God for salvation, for His eternal divine Atma to get solace, and also the family members, all the friends, all the disciples, all of us to bear this very irreparable loss. On behalf of the L.P.G group, on behalf of all the KGMC, all over the globe, the people associated with us, we pay our very sincere homage to him. And in honor of him, we will pray to Almighty God in 2 minutes time for कि उनकी आत्मा को शांति मिले, वो जहाँ भी हो वहाँ शांत रहे और हम सभी को आशीर्वाद अपने देते हैं। कृपया आप खड़े हो जाएं और 2 मिनट के लिए मौन धारण करें।
So to start with, again for the Google Meet users, the prostatic carcinoma is the second most common cancer in men, and it is the sixth leading cause of cancer death. In India, most of the patients is still present with advanced stage disease and metastasis, even with the widespread availability of PSA screening. Thus, the transrectal ultrasound-guided prostatic biopsy is an investigation of choice to diagnose prostatic cancer. It is performed in men with abnormal PSA, rapidly rising PSA, or palpably abnormality on the digital rectal examination, or it is used in cases of for diagnosis of suspected prostatic cancer, like when it present as a bone metastasis or cord compression, whenever the radiologists feel prostatic nodule or significant prostatic asymmetry. In this case, it is performed regardless to the PSA level, or the PSA level more than 4 nanogram per DL, or the free PSA less than 10%. So as for the postgraduate, for the diagnosis of prostate cancer, the free PSA should be less. As we know, the PSA is released in cases of benign prostatic hyperplasia, prostatitis, prostatic infarction. So to reduce the confounding with the BPH, it is better to do the PSA density, which is nothing but the PSA level divided by the prostate volume. Similarly, nowadays PSA transitional zone density is used, which is the PSA divided by transitional zone volume. Because from the transitional zone, most of the benign prostatic hyperplasia arise. The another factor is the PSA density, when it is more than 0.15, it is an indication for trust-guided biopsy. The other factor to reduce the confounding with the BPH is the PSA velocity, that is increase in PSA with time. When the PSA level is between 4 to 10 nanogram per ml and the PSA velocity is more than 0.75 nanogram per ml per year, it is a specific marker for the presence of prostatic cancer. As we know, the prostate gland is lies at the base of diaphragm and up to the urogenital diaphragm, and the base of bladder and the urogenital diaphragm. It has got the 3 zones, the peripheral zone, the central zone, and the transitional zone. The peripheral zone is most important because 70 to 80% of prostatic carcinoma arise from the peripheral zone. Peripheral zone generally located on the posterior and the posterior lateral aspect of the prostate gland and can easily be palpated during the digital rectal examination and a truss-guided examination. Central zone is around the ejaculatory duct. Less than 5% cancer originate from the central zone, but these tumors are aggressive and invasive in behavior. Transitional zone surround the urethra at the point of entry into the prostate gland. Only 20% cancer originate from the transitional zone, but they are considered as a good cancer because they are associated with a higher level of PSA, larger in its size, so easily diagnosed. They are slow to invade seminal vesicle and prostatic capsule, and recurrence after treatment is unlikely in the zone of transitional zone prostatic cancer. This is how the prostate look like on the radiology. Anesthesia used in the truss-guided biopsy, when I inquired from our urologists, they say they infiltrate 4 to 5 ml lidocaine at the base of bladder and the seminal vesicle. But when I searched the literature, the most effective method of pain during procedure was intrarectal local anesthetic administration or lignocaine spray, 15%. Otherwise, we can use periprostatic block anesthesia or direct infiltration. A spring-driven 18-gauge needle core biopsy device or biopsy gun is used. And this is the diagrammatic representation how this gun is introduced through the help of transrectal probe, and we take out a 12-core biopsy. In our department, generally we receive 12-core biopsy from the 12 different cores. When we divide into the right and left, on the right side it is a right lateral basal, right lateral mid-zone, right lateral apical, right medial basal, right medial mid-zone, right medial apical, and similarly the 6 core from the left side. At times we receive 6 cores, at times we receive 2 to 3 cores. It is actually when the disease is advanced on radiology or on this palpation, and when the urologist or radiologist is sure about the high-grade disease, then we receive the 6 core or even 2 to 3 core. But ideally, it should be 12 to 14 core, and all the 12 core should be received in the 12 separate site-specific labeled container. 1 core per container for each specific site. Sometimes we receive more than 1 core. It may be due to fragmentation, or it may be due to the urologist is not sure about the first core. All the reporting of prostate guided biopsy is performed by the recommendation of ISUP or GUPS. For the postgraduate, International Society of Urological Pathology and the Genitourinary Pathology Society, which is established in the 2018. All the recommendation made by ISUPs and GUPS, and we are doing reporting at present by the needle biopsy specimen level CAP approved June 2021. This biopsy, it can be reported for certain thing, it will be case specific, but other thing it will be specimen specific. Specimen specific means every core should be reported separately. First of all, see the treatment effect. If there is a treatment effect, hormonal ablation therapy or radiotherapy, like in hormonal ablation therapy, pycnotic nucleus, abundant vacuolated cytoplasm, or in the benign gland basal cell hyperplasia or fibrosis, or in the radiation-induced changes like hyperchromatic nuclei or vascular changes, whenever the treatment effect changes seen, please do not grade Gleason score or Gleason grade. All the positive specimen sites should be reported separately. If suppose 6 biopsy specimens are positive, you should report all the 6 sites, and each individual core should be reported separately. Yes, for histological type, you can do the case specific. Like as we know, 90% of prostatic carcinomas are adenocarcinoma, and less than 1% are other like pure squamous cell, basal cell, urothelial, or neuroendocrine carcinoma. So this protocol does not apply for other type of carcinoma. But if suppose the mixed carcinoma is present, we can use this protocol. But as of now, we know the percentage cutoff is very necessary to diagnose a mixed carcinoma, and which is not possible on the truss-guided specimen. So on the truss-guided specimen, it is better to write like adenocarcinoma with mucinous features, adenocarcinoma with signet ring features, so on and so forth. Gleason score and grade is most important for this reporting. As we know, it is also important for active surveillance and normogram. Generally, urologists used to say cut a normogram and pattern table. With these normogram, with the help of Gleason score, with the help of PSA level, with the help of stage, they can decide the treatment decisions. So this Gleason score is important for active surveillance. Active surveillance is nothing but wakeful watch. No medication, no radiation, or no therapy. In the active surveillance is applicable when small focus is present. It is confined to the one area of prostate. It is not causing any sign and symptom, and the Gleason score is less than 6 or 6. In the active surveillance, we do the digital rectal examination every 6 months or so. PSA examination and USG or MRI. Whenever any abnormality detected, when rising PSA, abnormal nodule, then we perform again the truss-guided biopsy. This is the famous diagram of the Gleason grade. I am not going into detail about the histology part. In needle biopsy specimen, how will we grade Gleason score and Gleason grade? No tertiary pattern is given on the truss-guided biopsy. It is the Gleason score, which is the sum of most prominent Gleason grade and the worst non-predominant Gleason grade. If no secondary grade exists, we just double the primary grade to arrive a Gleason score. Gleason score is assigned to each and every separately identified positive core, each and every core. Like situation, if the 95% is the Gleason pattern 3 and less than 5% is the Gleason pattern 4, then the score will be 3 plus 4. But if the opposite happened, if the 95% is the Gleason pattern 4 and less than 5% is the Gleason pattern 3, then the Gleason score will be 8. Because the rule apply is the minor secondary component if less than 5%, if it is of higher grade, only then it is reported. Suppose in another situation, if the 75% Gleason pattern 3, 20 to 25% Gleason pattern 4, and less than 5% is the Gleason pattern 5, then the score will be 3 plus 5. the most predominant and the highest grade should be reported. Similarly, if the 3 biopsies, it is generally happen in the MRI guided target biopsy, we receive 3 biopsy. 3 biopsy in the right lateral apical region, 1 biopsy core having Gleason score 3+3 in 80% core, second biopsy 3+4 in 40% core, and the third biopsy 4+4 in 5% core, then the composite score for all the biopsy will be 3+4. If suppose more than 2 biopsy core are positive in one side, we can give individual score or as a composite score for that particular site. Cribriform gland, it is another included in the latest classification. As we know, grade 4 present as a fused gland, poorly formed gland, cribriform gland and glomerulation. In this, the cribriform gland is an independent predictor of poor outcome, especially in Gleason score 7. So please write down if you see the cribriform gland in the report. The core showing only perineural invasion. No Gleason grade is given on the core showing only perineural invasion. If the limited carcinoma of few glands or tumor microfocus is present, don't try to grade this. Always remember these 12 points of the carcinoma prostate before making a diagnosis. That is enlarged nucleus, prominent nucleoli, mitotic figure, amphiphilic cytoplasm, rigid luminal border, mucinous secretion, thick eosinophilic secretion, crystalloid, mucinous fibroplasia, perineural invasion, and glomerulation. So always remember, always see the limited focus before giving the diagnosis of cancer. Also, we have to grade group along with the Gleason score. Grade group 1 means Gleason score 6. Grade group 2 is 3+4. Grade group 3 is 4+3. Grade group 4 is 8, either 4+4, 5, 3+5 or 5+3. Grade group 5 is 9 or 10, that is 5+4 or 5+5. Along with the Gleason grade score, you also have to grade groups. Then another thing included, you have to give the percentage of pattern 4 in all Gleason score 3+4 or 4+3. 3+4 means grade group 2. Here you can give the percentage in 5% difference, that less than 5%, 6 to 10%, 11 to 20, 21 to 30, 31 to 40 or more than 40. Why it is significant? If the patient is having Gleason score 7, 3+4, that is grade group 2, and if the pattern 4 is less than 10%, so these patients are eligible for active surveillance. But this rule applies only when the percentage of pattern 4 is 8 in another biopsy code, then don't try to give percentage of pattern 4 in the code. If another code is showing pattern 8, another code showing Gleason score 8, then there is no need to give the percentage of pattern 4 in grade group 3+4. Similarly, in grade group 3, that is 4+3, the percentage of pattern 4 is important. It is given as less than 61%, 61 to 70, 71 to 80, 81 to 90 or more than 90. So, but again here, if the another core is showing Gleason score 8, then there is no need to give the percentage of pattern 4 in grade group 3 lesion. Here it is important, if there is a percentage of pattern 4 is more than 80% in grade group 3, then it is an indicator of poor prognosis. Intraductal carcinoma, as we know, it has got an independent prognostic value. You have to be very careful and to differentiate between the high-grade pin, intraductal proliferations and intraductal carcinoma. There is a difference between the ISUPs and GUPs. Although no grading is given in the pure intraductal carcinoma, both by ISUPs and GUPs. But if it is present along with the invasive carcinoma, ISUP says incorporate this IDC in determining grade, while GUP says not include in determining grade. So if you are incorporating this in determining grade, please write down we are following the ISUP recommendation. Similarly, there is a little bit controversy for the quantitation of the tumor. As the prostate cancer volume is an important prognostic factor, we have to determine all the positive cores and divide it by total number of cores. If the 6 core are positive out of 12, the score will be 6 by 12. But we have to define the percentage of prostatic tissue involved in each and every core, along with the, if possible, the linear measurement of in millimeters. If we are not doing this, then at least give in the report the maximum involved core. More than 50%, this is an exclusion criteria for active surveillance. So you have to give the percentage of core as well as linear involvement of the core. Suppose this is the target biopsy and the 3 biopsies are received. One was involved 5 mm, second was involved with the length of 2 mm. So the composite score will be 5 plus 2, 7 positive, and the total length 13 plus 16 plus 6. So it is the total 20% involved in that particular site. But there is a difference when the core is discontinuous involvement. Suppose there is a core of 20 mm, 5 mm involved at both the sides. So the total is around the 2 mm, that is 10% involvement. But the recent study says you have to give the linear extent from one pole to other, also involving the intervening benign gland. Recording of cancer length from one end to other correlate better with radical prostatectomy finding and prognostic outcome than subtracting the intervening benign tissue. So it is up to you. Because some of the study says that 70 to 80% of discontinuous cancer foci might represent the single focus. It is because of the direction of the needle. We are seeing the 2 core with the 2 positive side at both ends. So it is up to you whether you follow this or not. That the local invasion, always clarify your diagnostic difficulty in the report while writing like extraprostatic fat invasion or extraprostatic seminal vesicle invasion. So we know that fat is generally not seen inside the prostate gland, and any fat with the malignant gland, we label it as an extraprostatic extension, and this stage will be 3A. Or similarly, for the seminal vesicle invasion, it is the rule that it should be the extraprostatic portion of the seminal vesicle, and the muscle of the extraprostatic portion of the seminal vesicle has to be involved. In the TRES-guided biopsy, we don't know whether it is the intraprostatic fraction or the extraprostatic fraction. Sometimes it is very difficult to differentiate between the ejaculatory duct and the seminal vesicle. Sometimes the seminal vesicle looks too complicated, or it looks like the malignant gland. So you have to look for that pigment in the seminal vesicle. And it is better always don't overgrade and clarify your diagnostic difficulty in the report for the local invasion. As it is generally not seen in the TRES-guided biopsy, but once I have made this mistake, that is why I made this slide. The most apical portion of the gland, the skeletal muscle of urogenital diaphragm extend into the gland. So if on the apical region in the radical prostatectomy specimen, we find the malignant gland and the muscle core, don't label it as an extraprostatic extension, because generally the muscles are seen at the apical portion of the gland. Perineural invasion, again a little bit controversial topic. It is associated with the extraprostatic extension in correlative radical prostatectomy specimen, but its significance is questionable in the multivariate analysis. But I was attending one conference of uropathology. They say, please give the perineural invasion with each and every separate core. Atypical ductal proliferation, this is another term, little bit confusing. It is the loose cribriform intraductal growth of neoplastic cells lacking significant nuclear atypia or intraluminal necrosis. Nowadays, cribriform high-grade pin is regarded as atypical intraductal proliferation. So if we see the atypical intraductal proliferation, please mention this as ancillary finding in the report. Presence of AIP in the needle biopsy may represent the unsampled intraductal carcinoma and has been shown to be associated with adverse pathological features in radical prostatectomy. Always try to differentiate the intraductal carcinoma, atypical intraductal proliferation, and high-grade pin. High-grade pin, if it is generally referred to the high-grade pin is low grade pin is not used generally. Reporting of pin in the presence of carcinoma is optional. But if isolated pin is present, if it is present on more than 2 sites, then it is to be reported. That's all. So to summarize the things, it is just for all the trust guided biopsy, it should be received in the 12 separate course, because our gleason grade may decide the course of action, whether we put this patient on the active surveillance or not. Always give all the positive code should be reported separately. All the positive code, the gleason grade should be separate. Perineural invasion should be separate. Percentage of grade 4 in all grade group 2 and grade group 3 lesion, unless until the 4+4 is present in other course. And try to don't overgrade or don't over commit around the extraprostatic extension on the trust guided biopsy. And now I would request our seniors to please add on this. If something. Yeah.
Thank you for summarizing the guidelines for reporting. I am audible, but it won't travel. Okay, doesn't matter. I can. When I read the topic, I thought he would kind of talk about differential diagnosis and difficulties in differentiating the adenocarcinoma from other possible limits. But this is a different focus. So there is too much to add. Right? The topic can be approached from several angles. This is one angle. So what she has talked about is the guidelines on how to report when you are rightly on the slide and how to report the diagnosis of carcinoma. I think we don't have time here to go into mimics or variations in histology and different grades, etc. And that's why you try to avoid them. That is fine. The only thing that I would like to add for people who are just getting into the subject is that the diagnosis of prostatic carcinoma sometimes appears difficult. And it appears, I remember a colleague who said, please don't give me prostate, don't give me thyroid. Why? Because the diagnosis of malignancy sometimes is difficult. It is difficult because we look for atypia when we diagnose malignancy. And atypia generally is considered as synonymous with pleomorphism. I just have to add here this line that atypia is not necessarily pleomorphism. Enlargement of nucleus is also atypia. And that is what we have to remember for prostate. For prostate, we have to remember that enlargement of nucleus, presence of nucleolus, and amphiphilic cytoplasm. These are the cytological characteristics of carcinoma. And infiltrated growth, that is, presence of acini which are irregularly distributed, which are linearly distributed, which are not in a lobule, and presence of small glands in between the large glands, that is architectural characteristic of carcinoma. Infiltrated growth pattern, atypia, and the other histological features will give you a diagnosis. The 12 features are here.
Thank you, ma'am, for the wonderful talk, and it's always wonderful to listen to you, sir. So please join us sometime to give us a talk on prostate, sir. Our next speaker is Dr. Major Sharanjeet, who is a consultant in Command Hospital. So, Dr. Sharanjeet, please join us on the podium.
Good afternoon, all. First of all, I bring my greeting from Command Hospital, Lucknow, and thank you for inviting us for this occasion. Today, I will be presenting an autopsy which was done in Command Hospital last year in July 2021. I have just added this slide because in July, when I was giving my final MD exams, so some external examiners were asking, what is this? So this is for PGs that you might also be asked this, that what is the meaning of this sentence. The patient is a 29 years old, fit serving soldier. Date of admission was 12th of October and date of death was 13th October and the date of autopsy was done on same day, that is 13th October. Clinical diagnosis was massive GE bleed with refractory shock. It was a complete autopsy with brain. Coming to the external examination, he was averagely built, pale, abdomen was distended, pleural and pericardial cavity contained 30 and 15 ml of straw colored fluid each, and peritoneal cavity revealed 1 liter of blood mixed fluid. Coming to the history, he had a history of RPA in the month of July, following which he was operated and then he was sent on 1 month of leave. After 1 month, he reported with myositis ossificans of temporalis muscle, for which he was again operated and was sent on 1 month leave. After 1 month, while on leave only, he presented to the dental OPD again for some opinion. While some dental procedure was done, he had a history of syncope. He also gave history of hematemesis and melena for 3 days. On clinical examination, he was drowsy and he was having hypotension. He was admitted and urgent GI endoscopy was done, which revealed active bleeding in the D2 segment, for which a metallic clip was placed. Investigations which were done revealed anemia with a HB of 5, thrombocytopenia, that is 90,000 per cubic mm, acute kidney injury, had creatinine of 3.4, transaminitis, hypoalbuminemia with albumin of 1, and prolonged prothrombin time. Grossly, in the peritoneal cavity, there was a bleed which was present in the peritoneum, that is the lesser set. Before this, when he was admitted, endoscopy revealed esophagitis and an active bleed. This photograph, it shows the gross appearance of a hemorrhage that was present in the lesser set. This photograph, it shows the gross. He had a metallic clip which was placed in the second part of duodenum, which was about 2 centimeters from the pylorus, along with a small perforation which was 1 centimeter distal to this metallic clip. This is again the gross appearance of the metallic clip which was placed, revealed pylorus and duodenum. Again the same photographs, that is serosal and the mucosal aspects. This is photomicrograph which shows H&E stain section from duodenum. It just revealed some, there was ulceration and some chronic inflammatory infiltrate was there, which was present transmurally. Coming to the stomach, it was also congested, and stomach was congested, and on the photomicrograph which, on histopathology, it revealed there was ulceration along with transmural inflammatory infiltrate. So what we got from stomach and small intestine, it was just chronic moderate gastritis. Large intestine was unremarkable. Except for duodenum, small intestine and large intestine, histopathology, it was unremarkable. Now, the question comes that whether this perforated duodenal ulcer with moderate chronic gastritis, can this explain the massive bleed? Further, other organs, coming to the liver, it weighed around 1500 grams, which is normal for this age and sex. External appearance, the liver was very pliable and it was soft and smooth in consistency. The cut external, we can see the high part, the external appearance. Cut surface, it revealed a mottled appearance. Now, this photomicrograph, it shows the section from a H&E stain section from the liver. Whenever we approach a liver biopsy, we have to see it under some heads, like whether the architecture is maintained or it is lost, then whether hepatocytes there, apoptosis or necrosis is there, then if there's any evidence of cholestasis, and then we have to look for the portal tracts, whether there's edema or inflammation in the portal tract. And finally, we have to look for what is the type of inflammatory cells in this portal tract. What we have marked blue, it is a central vein. In the red triangle, it marks the portal tract. On this high part, what we can appreciate is this one is bile duct tube, then hepatic artery, and this is a portal vein. This is a central vein. There is this necrosis which is present around the central vein. So from pattern of necrosis that is seen on biopsy, we can have some idea about the etiology. Like mostly if it is centrilobular around the central vein, we say it's generally, if it is due to viral hepatitis, it is hepatitis B and C, and hepatitis A mostly it generally causes periportal necrosis. So there were some viable hepatocytes around this necrotic area. On special stain, that is reticulin stain, it showed preserved reticulin framework. Further, on the higher magnification of this viable hepatocytes, we can see that these hepatocytes, they are showing nucleomegaly, there's some multinucleation and molding. So these are the three M's, which is multinucleation, marginated chromatid, and molding. And the blogs, they were sent to PGI Chandigarh for confirmation, and thanks to Dr. Subhradeep Mitra, he is in Department of Histopathology, KGMU Chandigarh, and the IFC for HSP2 was positive. So, the final diagnosis which was given was, this is a pattern, that is acute hepatitis with confluent necrosis, and etiology was herpes simplex virus 2. Coming to rest of our organs, pancreas and spleen, they revealed normal gross and normal microscopy. Kidneys, they weighed 380 grams. External appearance was smooth. Capsule could be stripped off easily. The cut section, it revealed maintained corticomedullary differentiation. Pelvic acyl system was normal, and ureter was also normal. On H&E stain section, we can see that there are tubules which are showing acute tubular necrosis. The glomeruli, it appears normal. Lungs, they weighed 850 grams. Grossly, the external surface was smooth, shiny, and cut surface, tracheobronchial tree, it appeared normal. However, on pressing, it exuded some pink frothy fluid. And, on this photomicrograph, it shows appearance of lung, which shows some presence of some fluid in the alveolar spaces with extravasation of RBCs into the spaces. Heart weight 310 grams, grossly it was normal, and it was dissected following inflow-outflow technique. It is a right inflow tract, right outflow tract, left inflow and left outflow tract. Microscopic appearance was normal. These are the along RCA, LAD, LCA, and L6. They did not show any occlusion or thrombus. Aorta was normal. Coming to the brain, it weighed 1300 grams, which is normal. And there were some red neurons. These red neurons, they just denote that there is some ischemic event, and because of that, that is due to necrosis or apoptosis, that these red neurons are seen in the case of sudden ischemia. Sections from bone marrow revealed a normal cellular reactive bone marrow with all three cell lines. Sections from skeletal muscle, thyroid, adrenal, skin, they revealed normal histology. The final autopsy diagnosis, which was given, was that in 29-year-old serving soldier with clinical diagnosis of massive G bleed and refractive shock. The diagnosis was acute necrotizing hepatitis due to HSV2 virus. Then perforated duodenal ulcer, extensive acute tubular injury, pulmonary edema, and hypoxic changes in the brain. These were the salient microscopic findings. A little bit about the discussion of this HSV hepatitis, why we are discussing it today, because it is a very rare entity and mostly it is missed. It is responsible for around 1 to 2% of cases of hepatitis. There is a paper which we have quoted in a meta-analysis of 147 cases across 5 institutions. Hepatitis is a rare complication of herpes simplex virus. It often leads to acute liver failure or death. More common in males, that is 62% patients are males and 38% are females. Immune status generally, we say that it affects the immunocompromised, and in this 53%, mostly they are the solid organ transplant recipients which are affected, and 24% are healthy, and 23% generally it takes place in pregnant ladies. Fever is present only in 98% cases, and the hepatic lesions, 56% of patients, they had no skin lesion. Only 27%. So it is easily missed because most of the patients, they will not have any skin lesion. So it will be, it is very difficult to for the clinicians to even think about this entity. And the 17% will have a disseminated herpes infection. Mean ALT-AST level was 4927 units per liter, and mean total bilirubin is 6 mg per deciliter. Hematology parameters, leukopenia, thrombocytopenia, and coagulopathy is shown. They are present in patients. Acute renal failure is present in 65%, and hepatic encephalopathy is present in 80% of the patients. So most of the cases, they are caused by HSV2 serotype, that is 62%, and only 38% they are attributed to HSV1. Most of the patients, as you can see, they are diagnosed only on autopsy. That is 57% of patients, they got diagnosed at autopsy, and rest were on liver biopsy, explanted liver or clinical criteria. And the mortality rate is very high, that is 75%. So most of patients, they die because of this infection. What was the possible pathophysiology in the index case? That as he was immunocompetent, HSV2 virus might have been dormant in the ganglia, and because of the stress in the RTE which he sustained, because of that, it got reactivated and it homed onto the liver from the ganglia, and leading to acute necrotizing hepatitis, which led to coagulopathy, and leading to extensive bleed from the nascent duodenal ulcer, which led to loss of blood and finally the refractory shock. And it is also known that any dental procedures, if done, they can also lead to reactivation of this virus and homing and dissemination into the various body organs. I've finished.
Sharanji for enlightening us for such a rare case of HSV hepatitis. So before proceeding with the interesting case presentations, I would like to welcome Nuzhat ma'am and Rashmi ma'am and Madhumati Goel ma'am, who has joined us online. So we'll be proceeding with interesting cases. First case is by Dr. Nilima Gupta, who is a junior resident in SDPGI. She's a senior resident in SDPGI. Good afternoon to all. Myself, Dr. Nilima from SDPGI. I'm presenting a case of 39-year-old female with complaints of breathlessness since 2 months, which was insidious in onset and gradually progressive. Patient has no history of fever, weight loss, chest pain, or pedial edema, or any neurological complaints or menstrual complaints. On general examination, patient had a right side decrease of breath sound with massive pleural effusion, and per abdominal examination, no mass was palpable. However, mild ascites was present. Patient took ATT because of massive pleural effusion for 2 months, and because of derangement of liver enzymes, he stopped the ATT. Because of pleural effusion, they sent the pleural fluid for the cytology. Pleural fluid smears were showing only a few reactive mesothelial cells. These are reactive mesothelial cells. The cytology smear was negative for any malignant cells. Then patient came SDPGI because of pulmonary symptoms in the pulmonary department, where CCT chest and abdomen was done, and the tumor markers were done, which were within the normal limit. See, this is a contrast enhanced CT image showing right side pleural effusion. This is another MIP view showing a large pelvic mass, which was incidentally diagnosed on CT scan. The mass was heterogeneous enhancing mass in the pelvic region. This is the whole mass in the pelvic and abdominal region. This is the MRI sagittal view. Here we can see the mass, which is abutting to the abdominal wall and the vertebra. This is another coronal view. Here we can appreciate this cauliflower-like mass. And this is another T2 image showing the bilateral ovaries are normal. So because of abdominopelvic mass, the patient was referred to urology department for the robotic assisted surgical removal. In urology department, robot assisted surgical removal was done, and examinations for the abdominal mass with the multiple forms like projections. However, bilateral ovaries were healthy. This is a mass. Guess any diagnosis or any differential diagnosis? So this case first received the core biopsy because it was a huge mass
in the pelvic and abdominal region. Origin was not clear but on the CT scan. So we received this core biopsy. In this section, here we can appreciate this is a mesenchymal tumor with the interlacing fascicles of the spindle cells. This is hyper. Can appreciate these tumor cells, spindle cell tumor cells. This is a high power image. Here you can see the tumor cells are showing minimal pleomorphism, round spindle cell shape with dispersed chromatin and inconspicuous nucleoli and moderate amount of eosinophilic cytoplasm. After that, we received the surgical specimen. This is a section from the tumor. This section taken with the myometrium and the tumor. We received this tumor with the part of uterus and fallopian tube. This is another view. Here you can appreciate tumor's cell morphology. Tumor cells are in a spindle in a shape with interlacing fascicles. This is another view. Here we can appreciate this tumor infiltrate into the wall of uterus. And this is high power view of the image showing the tumor cell morphology. Tumor cells are largely monomorphic, showing a spindle in a shape with inconspicuous nucleoli and moderate amount of the cytoplasm. Mitosis are infrequent, only 4 to 5 per 10 hyperfield. Section from the fallopian tube shows the unremarkable fallopian tube. So, on the basis of histology, these are differentials. But because of no mitosis, no necrosis, or no nuclear atypia, we can exclude these malignant lesions. So, we have kept these benign lesions. So, applied Vimentin, which was positive. The smooth muscle actin was positive. S100 considered negative. And Ki-67 index only 1%. So, the final diagnosis was cotylednoid dissecting glioma. This is a very rare type of glioma. And the patient presented with a pseudo-Meek syndrome, not the abdominal symptom. So, what is a Meek syndrome? Meek syndrome is defined as the presence of ascites and pleural effusion in association with benign ovarian tumors. With pseudo-Meek syndrome, generally patients have abdominal tumors and presented with the ascites and pleural effusion. Few words about cotylednoid dissecting glioma. The cotylednoid dissecting glioma is a rare variant of uterine smooth muscle tumor. It's an unusual growth pattern that shows the intratumoral dissection within the uterine myometrium, often presented like placenta or cauliflower-like appearance. That's why it's called as dissecting glioma. Thus far, over 30 cases are reported till the date of these cotylednoid dissecting glioma, and none of which have described with the pseudo-Meek syndrome. In this case, a patient presented with the pseudo-Meek syndrome. Echomasses, it is important to think pseudo-Meek syndrome as an of the differential diagnosis of uncontrollable pleural effusion. These are our references. Thank you.
Ma'am, after the removal of the tumor, patient is well. All the pleural, breathlessness and dyspnea are gone.
Ma'am, after removal of the tumor, patient is well and breathlessness and dyspnea.
Did you do any other marker apart from SMA? Apart from augmenting in SMA, did you do any other marker to show that they are smooth muscles? SMA doesn't prove that they are smooth.
She's better.
It showed the histology and there was a triangular mitosis there. So have these mitoses been divided in this population various like you do have a very
4
small
to 5 per 10 high pass filter.
that's very high. It's also goes into a
But the presentation and the history.
back to the histology, there's actually a triangular mitosis. They're very rare benign conditions where they do describe.
Ki-67 index was very low.
I don't know if they describe it this way.
So 4 to 5 mitosis is there. Per 10 hyperfeed.
Actually, it's different for different types of tumors. Some tumors
Yes.
and myxoid.
So only one. Yes,
If you're looking at the conventional cutoff is like 10, I think. So I'm doubting.
So like whenever you considering this to be like it's not myxoid obviously.
Yes,
You're looking at a
because of
cutoff of
morphology.
more than 4%, sometimes more than 10 to 12%. And with the abnormal mitosis, did you count more? I would have to find.
The Ki-67 index was very low, only 1%.
Variegated mitosis count is wrong.
No, some mitosis was there. Some mitosis was there.
Have you put on the Ki-67 index on the same slide where you have counted the mitosis?
Yes, ma'am.
Then either of them, there is the error in either of them, right? Because the mitosis can be heterogeneous in large tumor. So you have to, look all the slides, then identify the mitotically active areas, then you count it. Then count, if you have counted the mitosis in a particular site, so I think it is preferred that you put up the Ki-67 on the very same slide. So if you are saying that you have done the same, so then either the mitotic count is wrong or make the error on the Ki-67. Because the Ki-67 is very much dependent on the fixation. If there is a delayed fixation, even 1 hour of the fixation, it has been reported, especially in the breast cases, that even 1 hour of the delay in the fixation, in some cases, may reduce Ki-67 by up to 50%. Like up to 50%. So I don't know, and then abnormal mitosis. So I doubt like the Ki-67 would be 1%.
Thank you.
Thank you.
So cases can always be reviewed because we have good, very learned people sitting over here, so we can always review if any doubts in the cases. Our next speaker is Dr. Surbhi Gupta. She's a consultant in Vivekanand Polyclinic in IMS.
Good afternoon, everyone. Myself, Dr. Surbhi Gupta, from Vivekanand Institute of Polyclinic and Medical Sciences. I'm going to present an interesting endometrial biopsy finding
in a case of primary infertility. 25-year-old housewife attended the gynae OPD in our institute with a history of infertility. She was unable to conceive last 3 years of her marriage. Her menstrual cycle was regular and no history of any medication and drug abuse. On laboratory investigation, her complete hemogram and blood biochemistry, including hormonal profile, was normal. Semen analysis of her husband was also within normal limit. Transvaginal sonography findings were hyperechogenic mass, patchy calcification, and hydrosalpinx. Hysteroscopy reveals adhesion over fundus of uterus and bony tissue in the endometrial cavity. This is a hysteroscopic picture. Here we see the bony tissue inside the uterine cavity or endometrial cavity. This is a similar another picture of the hysteroscopical finding. Here we see the bony tissue in the endometrial cavity. Hysteroscopical removal of the bony tissue was done and submitted for histopathological examination. On histopathological examination, we received multiple tiny, irregular, hemorrhagic, soft to hard tissue bits, altogether measuring 2 into 1.5 centimeter. After decalcification of bony tissue, paraffin section was prepared. Microscopic examination, endometrial tissue showed endometrial glands, they are in proliferative phase. Stroma was densely infiltrated by acute inflammatory cells. Patchy area of calcification along with well-formed bony trabeculae was there. This is endometrial biopsy. Here we see the endometrial glands. They are in proliferating phase with compact cellular stroma. This is a high magnification of the endometrial glands in proliferative phase with compact cellular stroma. And this picture shows the stroma is densely infiltrated by acute inflammatory cells. Similar another picture of the stroma, which is densely infiltrated by acute inflammatory cells. A dense polymorphs are there. This picture showed endometrial tissue along with an area of calcification. Here we see the bony trabeculae. Bony trabeculae, it is surrounded by the area of hemorrhage. In this picture is a magnified view. Here we see the bony trabeculae and area of hemorrhage. This is a very important finding related to our case. Here we see the well-formed bony trabeculae enclosing the non-hematopoietic bone marrow. This is a high magnified view. Here we see the stromal cell, that bony trabeculae surrounding the stromal cell. And this is a very important finding. Stromal cell is there, but they are we see the continuity of the stromal cell with the bony trabeculae. This is a magnified picture. This is here we see the stromal cell, the continuity of the stromal cell with the bony trabeculae. It means there is a metaplastic transformation of endometrial stromal cell into the osteoblast, that further formation of mature bone formation. This is a picture where we see the area of calcification within the stromal tissue also. So, but final diagnosis is osseous metaplasia of endometrium. Now I will discuss WHO classification of endometrial metaplasia and related changes. So, two type, epithelial and non-epithelial metaplasia. Epithelial metaplasia, it's in the glands, squamous metaplasia, or non-epithelial metaplasia, it's a stromal, mesenchymal tissue converted to different like smooth muscles, cartilaginous, fatty changes, glial tissue, foamy cell, and osseous metaplasia. And these are salient features in our presenting case. Patient had a primary infertility, whereas in literature, more than 80% cases are associated with history of previous pregnancy. No history of conception, abortion, or intrauterine contraceptive device. And in our case, there are dense inflammation of polymorph present in the stroma, which may be the cause of osseous metaplasia. Because of the dense inflammation, it's called the dystrophic this is osseous metaplasia, and this ossification may lead to because of pluripotent stromal cell. And pyometra has been mentioned as one of the cause of the osseous metaplasia in the literature. At last, the carry-home message. Presence of bony trabeculae in the endometrium is not always associated with abortion. Besides clinical history, thorough histopathological examination is rule out the possibility of osseous metaplasia. Osseous metaplasia may be a cause of primary or secondary infertility. Hysteroscopic removal of bony tissue is a gold standard treatment for this condition, and which often lead to spontaneous conception. In our case, entire bony tissue has been removed by hysteroscopy, and now patient is under follow-up. Thank you.
Well, this was an interesting case. Next case is by Dr. Shaila Fayaz, who is a junior resident in KGMU.
I kept this case because more than 5 people sent me reporting on endometrium. I thought the first day on orthodontologia in the and the present very nice demonstrated the fertility of the common cell changing into the orthodontologia and integration and everything. I thought first case in my life at this age that orthodontologia in the calling call off, and we primarily most of the time it was only in India, but it's a first.
Good afternoon, everyone. Myself, Dr. Shaila Fayaz. I'll be presenting an interesting case of 50-year-old female who presented with anterior neck swelling for one and a half years, which was painless and slow growing in size. It was not associated with any compressive symptoms like dysphagia, dyspnea, or hoarseness of voice. On physical examination, swelling moved with deglutition. Most likely, it could be a thyroid swelling. It was associated with bilateral cervical adenopathy. On biochemical evaluation, thyroid function tests were normal. On radiological evaluation, on PET-CT, it showed heterogeneously enhancing ill-defined mass, largest measuring 10.4 centimeter, involving the entire thyroid gland, with bilateral cervical adenopathy. Then FNA's fine needle aspiration cytology was performed, which showed monomorphic population of plasmacytoid cells, which are round cells with eccentric place nucleus and a perinuclear halo. So we consider the probable diagnosis of plasma cell neoplasm. Based on the cytological morphology, our differential diagnoses include plasmablastic lymphoma, primary fusion lymphoma, and ALK-positive large B-cell lymphoma. Then, to narrow down our diagnosis, we ordered core needle biopsy, which showed sheets of atypical plasmacytoid cells with interstate area infiltrated by lymphocytes. On immunohistochemical analysis, plasmacytoid cells were showed diffuse positivity for CD138 and kappa monoclonality. Also, they were negative for CD20, 19, 20, and 30, and PAX5. Also, it was ALK negative. Further investigations were done to rule out certain conditions like multiple myeloma. On serum electrophoresis was performed, which showed normal values. Bone marrow examination showed normal hematopoiesis. On bone scan, no other foci of lesion was identified. So we narrowed down to a diagnosis of solitary extramedullary plasmacytoma of thyroid. Then the patient underwent external beam radiotherapy, which showed a complete response, and the patient is on regular follow-up since 5 years. Brief discussion about extramedullary plasmacytoma. As extramedullary plasmacytoma is a plasma cell tumor that develops outside the bone marrow. It is a rare entity that constitutes less than 5% of all plasma cell neoplasm. Thyroid involvement is even rarer and accounts for about 1% of all extramedullary plasmacytoma. Only less than 50 cases have been reported so far. Predisposing conditions like lymphocytic thyroiditis and neck irradiation have been shown to be associated with extramedullary plasmacytoma, but no specific study has been done till now. Before entering the diagnosis of extramedullary plasmacytoma, it is essential to exclude the possibility of multiple myeloma, as extramedullary plasmacytoma is a curable disease, whereas multiple myeloma is not. A diagnosis of extramedullary plasmacytoma of thyroid is confirmed along with the features of histomorphology. Plus, there should be a normal bone marrow examination, absence of osteolytic lesions on bone scan, and normal levels of protein serum electrophoresis. In about 15% of cases of extramedullary plasmacytoma, the disease can progress to multiple myeloma that may require lifelong monitoring. These are the differentials of extramedullary plasmacytoma, which includes plasmablastic lymphoma, primary fusion lymphoma, and ALK-positive B-cell lymphoma. It is important to differentiate between them because they have a poorer prognosis and the treatment modality differs. As plasmablastic lymphoma are also CD138 positive, just like our extramedullary plasmacytoma, but they are positive for CD30, but in our case, extramedullary plasmacytoma, which were CD30 negative. In primary fusion lymphoma, we see HHV8 positivity, and in ALK positive large B-cell lymphoma, we see ALK positivity. So treatment, people with extramedullary plasmacytoma may receive combination of therapies, which include surgery, radiotherapy, and chemotherapy. The recommended treatment for extramedullary plasmacytoma is fractionated radiation, including all involved tissues with a healthy margin of at least 2 cm. Surgery remains the treatment of choice if the tumor is resectable, but should always be followed by irradiation, as surgical extirpation carries a high recurrence rate. Chemotherapy is given in persistent disease cases after initial irradiation. Lastly, patients with extramedullary plasmacytoma has an excellent prognosis with a 10-year overall survival rate of 70%.
Good presentation, Dr. Shella. Next, we'll be proceeding with quiz. For quiz, I invite Dr. Madhu Kumar ma'am for presenting.
There is a quiz for the postgraduates. Are you ready, residents? Okay, I want to tell you a few rules regarding the quiz. If you know the answer, then firstly you raise your hand, then introduce yourself, your name and your institution. LE-cell in SLE, systemic lupus erythematosus, is also known as. Anyone? LE cell in SLE is also known as? Anyone? Yes, it's correct. And one more other name. Other name also. Also known as other name. One more name. Anyone? It's also known as a hematoxylin body. Okay, and one chocolate goes to Rupali. Okay. And next question, the famous singer shown in the image underwent renal transplant for complication of which disease? She is a singer and the disease name, the most of the, firstly you read.
KGMU, the name of singer is Rina Gomez and she suffered from SLE.
Okay. ठीक है. It's diagnosed with lupus nephritis. Yes. Okay, and next question. Identify the scientist who named the dramatic appearance and dramatic appearance also known as? The dramatic appearance is also known as, and also dramatic appearance also known as, bar body for no. Yes, bar bodies are basically we see in the buccal mucosa and the somatic cells. And the dramatic appearance is a non-specific appendages. And these are present in the neutrophils. Davidson bodies named after the Professor William Maclay Davidson. He is a Scottish pathologist and hematologist who first discovered it. And the next question is, a 32 years old female using IUCD on LBC smear identify the organism.
Marking from KGMU, actinomycosis.
Okay. And the chocolate goes to Himadri. Okay. And the actinomycosis is also known as, the one more name for actinomycosis is also yes, please. Yes, cotton ball appearance and one more name, the bunny dust, and one more other name, the Gupta bodies. Okay. She can get a chocolate. A special stain used to see the Azopardi effect. Azopardi effect or Azopardi phenomena. Special stain used to see the Azopardi effect. PS and other special stain. PS is also, and one more other name. More stain. Any DNA stain? For nuclear material? Any stain for nuclear material? Yes. Yes, fusion stain. Next question. Identify abnormal cell with pawn ball-like appearance, and it is found in the bone marrow sample of which disease? 3 golden ball like cells, abnormal cells found in the bone marrow in which disease? And the pawn ball-like appearance, the name of the abnormal cell in the bone marrow, the hint for it. Okay. It's correct. The pawn ball megakaryocyte found in MDS. Next question. A 17-year-old girl with a slowly enlarging left tibial mass. What is your diagnosis in this picture? And two more name of neoplasm with similar morphology. In the tibia, what is your diagnosis? And two other name with a different site. Yeah, speak loudly, please. Stand up. Stand up, stand up. Yes, in ameloblastoma in jaw. ठीक है? And in tibia, similar picture in tibia. Similar morphology, but sites are different. The diagnosis change. What? Adamantinoma. And in the one more diagnosis with the similar morphology. What? In brain, craniopharyngioma. That's right. Okay. So in the jaw, it's ameloblastoma. When located in the tibia, then it is known as adamantinoma. And in the suprasellar or sellar region, then it is called as a craniopharyngioma. The next question: which cancer are represented by pink and lavender color ribbon for cancer awareness program? Pink color and the lavender color. Pink and lavender color. Only for pink color and for lavender. No. For lavender? No. No. लेवेंडर कलर एक कॉमन नेम बता दीजिए कैंसर के लिए. कॉमन कैंसर फॉर ऑल कैंसर्स. लेवेंडर कलर इज फॉर ऑल कैंसर्स. ओके. एंड पिंक किसने बताया था ब्रेस्ट के लिए? Okay, this type. There is a different colors for the different type of cancers awareness program. And then the below day celebrated or International Pathology Day celebrated. When International Pathology Day celebrated? Try. November? Anyone? Any other? Yes, you are right. Yes.
17 December.
No, this is not December. Okay, it's November. The second Wednesday of November. Per year, every year. It is celebrated every year. Yes. You can get a chocolate. And International Pathology Day was launched in year 2014 by the Royal College of Pathology. And the next question, filling the gap in the name of general, the yellow color, the general of the blank, yellow color and the blank. Filling the gap in the name of general. This is the ectocytological general. Please fill the gap. The cytologists can tell international cytopathologists can tell.
Myself, Anuda Ganga, the General of Clinical Psychology and Psychopathology.
General of Clinical
Psychology
and
Psychopathology.
दोनों का cytology. The general of someone says clinical. No. For resident only. The general of
Pathology and
General of
Clinical cytology and cytopathology.
No. गूगल नहीं करना है भाई, गूगल नहीं करना है, ठीक है। इसके जनरल ऑफ क्लिनिकल पैथोलॉजी एंड साइटोपैथोलॉजी। Next question, the name of disease associated with the family. Yes, introduce yourself. Yes, you are right. Okay, it's correct. The next question, a 21 years female with history of polar colored urine. What is your diagnosis on these pictures? No. The past positive, basement membranes, IF, EM. See the pictures. Yes, Sugandha, you are right. Yes, this is a C3 glomerulopathy dense deposit disease. What is the system used for reporting pancreaticobiliary cytopathology? We know the various system, Milan system, Paris system, Bethesda system. Yes. Tapanukulo? ठीक से बताइए. Society of Cytopathology. Okay. And the next question is, where the Vancouver term used and the country where it is located. We are using in Vancouver style. Where is the country? Okay, referencing style of or bibliography. And the second part is country where it is Canada. Okay. That's right. And the last question is, identify the disease with this image look like. As it, the field, the green color field and a ball. Speak loudly. HP? Yeah. And this is a HBS disease or alpha thalassemia, and the RBC look like gold balls. There is a blue elevation on the RBC. And any special stain? Special stain? Identify this is the special stain. This is, what is this? This is a supravitalism. Okay, that's right.
Isha Mother from KGMU.
Okay. And now the resident का quiz तो खत्म हो गया. अब हमने अपने seniors के लिए भी quiz रखी हुई है. Sorry उसके लिए. माइक दे दीजिए. मैम को एक माइक दे दीजिए. हाँ एक मैम एक आप ले लीजिए. मैं एक आप नहीं मैम. Please identify yourself, your seniors, your juniors, your colleagues. At least 10 members. Yes, ma'am. Mastan Singh, sir. Yes, ma'am. Yes, ma'am.
And that is Gauri, that's Poonam Agarwal, then there's Anju, then Chan, Vicky, then that's Manjula, that's me, and that's Uma, that is Dr. Ashutosh Kumar, that's Sanjeev, and that's Dr. Sharma from the blood bank, Dr. Raj Malhotra in the middle, and I can see Dr. Dikshit, the fourth from the right, on the last row. Anybody wants to add more? Dr. Yassin Sahamedi. He's not there. Dr. Dikshit is number 4. He was doing.
मैम सारी चॉकलेट मुझे जाती है मैम one more picture मैम USC sir so
Dr. Nagesh, Dr. Ian, Dr.
Yes,
Kapoor, and Dr. Kushwaha, Dr. Pramod Nath.
Dr. Manoj Jain sir भी हैं
Natu in terms of Kapoor, Kushwaha, Dr. Pramod Nath, myself, Dr. Vanu, Bakshi, and Dr. UKK में
Yeah, there's Vinita, there's Seema Bhatt, then there's Vibhushi, there's Chitra Kohli, and there's Dr. Manoj Jain, and
Dr. Rajesh, second, right? Sunita, Dr. Sunita Agrawal, Chitra, Kohli. Dr. Seema Bhatt, ये Dr. Mishra, क्या नाम है? Sonatan, Sonatani, Mokta Gupta, पीछे डॉक्टर संगीता सोनकर, डॉक्टर विनय गुरनानी, बगल में डॉक्टर पांडे, आरसी पांडे, डॉक्टर मनोज जैन, डॉक्टर त्रिपाठी ये डीसीपी के थे, उनके पीछे संजय खन्ना, डीएस वर्मा, ये भी डीसीपी के हैं, इसके बाद मेरा है डॉक्टर सुरेश और सबसे लास्ट में डॉक्टर श्रीवास्तव।
Thank you sir, thank you ma'am. And the cytocon UP chapter 2023 will be held in which institute or university? So all of you are most welcome for the conference, and this is the last. Thank you so much. Thank you. Sir, would you like to say something? Sir, please. Sir, please.
I will invite Madam to say a few words of something.
I'm so happy to see the gathering today of youngsters, teachers. I used to work in Rakesh and Villa always taken the back. I used to take the top the front. And thank you very much, Dr. Getty, for 90 days meeting here and inviting everybody. I'm coming after many years, I think, to this meeting. And God God bless you. God bless everyone. Okay.
On behalf of the Department of Pathology, I'm really indebted and very much thankful to all of you that you have come and given your time for this very important academic week. And it has been possible because of the blessing of Governor Pandita, whose vision was to have this type of community. And it is going on for the last, I would say, a decade now, and with a fruitful result. I would like to invite our students.
Oh, I think it's all yours today. Very organized. Thank you very much. A big thank you to the Department of Pathology, KGMU, and we look forward to the UPIITM conference here. So thank you.
I would have loved to be there in the pathology department instead of there. Because I have never been to pathology department since I knew that Dr. Raj was the pathology department once. I think 2012 or 13. Only then I went there. So last time you said 2 days back I went, there was nobody in the so big department, but everywhere rooms were empty and so I would have loved to be there in the pathology department with the Today I told him that I am coming to KGMU to the meeting and I will come to you and I will tell you. He took the meeting here, they will come and
We still want to teach in the department, but there are like no online facilities and at the last.
Next is Dr. Akshana Singh from this department. The Martin और मुझे सब teachers थी इस department की. Whatever I am today is all because of this department and Martin. Thank you.
Thank you, Dr. Singh, for inviting me to that. It's very nice to see you again, sir, for the gathering. And my teachers there and my parents who had always been a guide to us. And this particular L.P.G is, it's like a blessing for all the practitioners because they gave us a chance to see the rest of the people that have around in Lucknow. And we are very grateful to whose representation is generally poor, but then still we always love to come to this. Next thing, we are thankful to you and to all our teachers, Madam, Dr. Pandey, Angela, who's our colleague, and all of you. Thank you very much.
Like that, you. That's a good. Thank you for organizing this meeting so well, and what should I say? Thank you to everyone who came, and thank you to all the speakers who spoke so well. And I don't see anyone here, maybe he has to go somewhere. He also spoke very well. Maybe we could have asked for more questions. So I wish that the meetings become more and more interactive so that more and more people interact and I can stay quiet. Thank you very much. In the end, other people can speak obviously, but in the end we will need to finalize the program again.
So I welcome Manojan sir.
For organizing so please started this meeting say to forget the Institute of Dr. Pandey. In the CPI first meeting was held. The quarterly, as you all will be knowing, the quarterly we are having meeting, rotating the common issues. During COVID time, that we could, otherwise, regularly we had meeting. I think this 30, yeah, I don't remember, but every quarterly we had meeting. And in 8 it was divided. Second was agency. So next meeting we will be taking maybe command can take or my so I think in April, initially to bypass winter and summer vacation, it was decided that but this meeting was scheduled for October last week or November 1st. We were giving to begin with, we were giving on the January, April, so that last Saturday of the January, and Friday original schedule is last week of January. Last week of January. But it is because October is keep it in March. March, April, May, as per your convenience. September is.
We can announce it. I think we want last week of March is fine. Last week of March. Last week of March, welcome to annual. Last Saturday.
Last Saturday.
Last Saturday.
Last Saturday of March, we will take in our we have got an L.P.G WhatsApp group, so anyone who is not can send request to any of the L.P.G WhatsApp group. And any suggestions or regarding the interactive program that can be taken. Request the team.
Okay, very highly enjoyable. So nice to see it all clearly. Yeah, very good meeting. My compliments and you conducted very well. Thank you so much. Very good.
Hello.
Thank you, sir. I'm Dr. S.K. Sinha, pathologist, but currently working as Chief Medical Officer at RDSO Hospital. I'm not known in the city. I'm new to the city actually. Month in Pathology this year. I got posted here. But because of my attachment to the subject, when I was during on meeting at Bangalore, Dr. Manoj got me included in the group. I really feel very nice after doing this meeting today. I thank the entire faculty of KGMU and just thanks a lot.
So this is my alma mater. So thank you, sir. It is a privilege to say something. So we have been connected to the L.P.G meeting since the beginning. Someone was asking me if you will come. So I said, if I'm not in town, then only I'll not come. Otherwise, if I'm in town, I will always come to the L.P.G. So it is such a nice meeting. And it is always a treat to meet everyone. Thank you so much for organizing this.
Thank you and welcome all of you in KGMU. Thank you.
With us, Molni with Okay, with us, Moni from NHS, a few words.
you everyone. So I am working with National Health Authority, Delhi Health Ministry. So I'm here to invite all of you for a workshop. Just a second. Yeah. So it's a event or a workshop from the National Health Authority in the Hilton Hotel, which is situated in Vibhuti Khand, Lucknow. So it's a diagnostic industry workshop where you might have heard about the ABDM, that is Ayushman Bharat Digital Mission, and there are various parts of it. The one part is the ABDM, that is Ayushman Bharat Digital Mission. It's nothing to do with the PMJAY Yojana. It's a second part of the ABDM. So we have been in a process of onboarding the labs. So that is why we are here to invite you. All the practicing pathologists are invited in this event. So I have requested ma'am also. I have given her the link for the registration of the workshop. So it will be highly obliged if you guys can come and join us for the event. The people from the health ministry also will be coming and giving an insight of how this work will go on. Thank you. Sorry, it's on 22nd of this month, 22nd December. Thank you. We'll be sending a personal invite also. I will take a list from outside. Thank you so much.
All of you, please invited for the high tea in the room number 105. 106. Ground floor.
Okay, to welcome all of you on the 25th of March at Ireland. We will try to